Good morning, everybody. We're just gonna let some people kind of file in here after Dr. Coffey's presentation. So give everyone a quick second. We'll go through a couple of housekeeping orders and then we'll let Dr. Boudreaux take it away. All right, looks like there's a lot of people joining. So I'll start with the housekeeping orders. We have, just to let everyone know that the session is going to be recorded today, and you can find the recordings posted on the platform for 30 days after the conclusion of the symposium. They'll also be added to the SBCNY website, and that link will be shared with participants at the conclusion of the symposium as well. CEs will be provided post-symposium once the attendance is confirmed and once the evaluation survey is completed by the participant. An evaluation survey will be sent via email to all attendees of the session at the end of each day. Please submit any questions that you might have in the Q&A tab. We will try to get through as many questions as possible at the end of Dr. Boudreaux's presentation. We hope you all have enjoyed the symposium so far, and Dr. Boudreaux, I'll let you take it from here.
Great. Thanks, Greg. I appreciate that. I'm going to share my screen now. We're good, Greg? You can see?
Yes, looks great.
All right, great. Well, it's a real pleasure to be here today. I appreciate the invitation. I'm going to be talking about opening Pandora's box in the emergency department. In other words, implementing universal suicide risk screening. So I'd tell you a little bit about myself before I jump in. I'm a clinical psychologist by training. I've worked in a bunch of different medical settings, but most of my research has really been focused in emergency medicine. So I'm really going to focus on emergency medicine today. But I think that what I have to say and the experiences that I have to share relate to a variety of different medical settings, because I've worked in those other settings, inpatient units, primary care, and other ambulatory practices. And I can tell you that the issues that we face and the resistance we face and the questions we have to answer are really more common than they are disparate. So I think that this has important implications for other work beyond the emergency department. So I work at UMass Medical School in Worcester. It's affiliated with UMass Memorial Health. So really we have a learning collaboration between the medical school and the health system. And much of what I'm going to talk about today was generated from that learning collaboration, but as well as several other projects that I'll summarize briefly. All right. So I have no disclosures to relate in terms of the content of this presentation. I want to start with a thank you for all of my collaborators who have helped with the career that I've had and the work that I'm going to share, including our research staff, clinicians, our frontline staff who are actually doing the work, patients and participants for our studies, and the individuals with lived experience have really informed my worldview on how this should work. Primarily, I'm going to discuss results from the ED-SAFE 1, but I also will be tapping into some of the experiences in ED-SAFE 2 in the system of safety. These are all multi-center research studies focused on implementing universal suicide risk screening, as well as other process improvements in ED-based care. The system of safety is the most recent, and it's a zero suicide grant that we received to transform the healthcare, the suicide-related care across the entire UMass health system. That was EDs, as well as inpatient medical, inpatient psychiatric units, and ambulatory practices. So what am I referring to when I say opening Pandora's box? I'm really referring to implementing universal suicide risk screening. And of course, the reason why we call it Pandora's box is because this is the biggest fear people have, is that what if I ask the question, about suicide and they say yes, then what do I do? You know, that's the fear people have. We'll talk a little bit more about that barrier and resistance to implementation in a little while. But why should we even consider opening Pandora's box? Why should we even consider something so profound and potentially difficult and challenging as universally screening for suicide risk in all emergency department patients who present who can actually be screened? Now, there's two primary sources of information out there in the literature that really suggests that we should seriously consider about universal screening, not just targeted screening like the Joint Commission requests, but universal screening. And the figure on the left is one you probably are familiar with. This is Brian Amadani's landmark study that looked at healthcare utilization prior to death by suicide. And what we see is that most people, 83%, have had some kind of healthcare in the year before they died, which might not actually be all that surprising. But what's really interesting is that only 45% of those patients received a mental health diagnosis in that period of time. And this is true for the emergency department as well. So around 40% of patients had been seen in an emergency department, but most of those visits were for non-behavioral health reasons. So these are people who are presenting to the ED, not for a behavioral health reason. Some of them are, a substantial proportion of them are being seen for a psychiatric crisis, but many of them aren't. And then they're dying by suicide in the weeks or months after that visit, which really calls us to ask, then, is there something better we could do to try to detect that suicide risk prior to the person dying? So the image on the right is a summary of a bunch of systematic screening studies where research staff would go and would screen patients in the ED systematically to identify if their suicidal ideation or suicidal behavior. And most of these studies were actually done with medical patients. So these are not patients who are presenting with frank indicators that we should worry about and screen them. These are medical patients or a mixed group of both psychiatric and medical patients. And what we find is when you ask the questions, anywhere from 2.4 to 8.4% will say, yes, I've thought about killing myself. And the time length for that differs from 1 week to 2 weeks. But in other words, I've thought about killing myself recently. And this is active suicidal ideation. This isn't just passive ideation, thoughts of they would be better off dead or wishing they would go to sleep and not wake up. These are actually people who have said, yes, I've thought about killing myself in the past week or two. And then if you ask about behavior, suicide attempts, you find that anywhere from around 8% to 18% have had either ideation recently or a lifetime suicide attempt at some point in their past, which really was way a larger proportion than anyone ever expected. So these two bodies of literature, which were separate, really can be combined to say, you know, the emergency department is a suicide-enriched environment, but we're missing most of the patients who have suicide risk by using our existing approaches of just screening patients who are presenting with frank psychiatric symptoms. So that led to the question, well, if we implement or can we implement universal suicide risk screening in an emergency department, and is it feasible to do? And if we do it, what happens? So the biggest resistance we get in the emergency department, and I say insert setting here because it's the same everywhere we go, whether we're talking about inpatient or ED or primary care, are the following barriers. So the clinicians who work in these areas are not trained to detect or to screen for suicide, and they're not trained to handle suicide. That's one objection we usually get. It's going to increase the amount of time it takes to do our assessments with patients. And in the emergency department, that's a really important objection. Obviously, the care has to go quickly, it has to be efficient, or else everyone in the emergency department suffers. We definitely don't want clogging in the emergency department. It's going to lead to patient dissatisfaction. So this is not the reason why they're here. And if we ask questions around suicide or other mental health, then it's going to lead to patient dissatisfaction is one objection. We don't have enough observers. If we identify all these patients that are suicidal and we don't really know they're suicidal, but we uncover it and now we know, then we're going to have to assign an observer for all of those individuals. And we just don't have enough of those observers to go around. And we also don't have enough behavioral health providers. So what are we going to do? How are we going to evaluate these patients? We already are struggling with evaluating psychiatric patients because there are not enough behavioral health providers. Adding more burden is going to make it even worse, and it's going to lead to increased boarding. So now we're going to have these patients who are going to be admitted to psychiatric facilities. There are no psychiatric facilities for us to admit them to, so it's going to jam up the emergency department, increase boarding, and that, of course, slows everything down for all patients, even those who aren't boarding. So the objection is it's simply not feasible. There's no way you can implement universal screening because it's going to break the emergency department. So this was the platform. This was the background for our first study, the ED Safe study. and it answered this question: is universal screening during routine care in the emergency department feasible? We recruited 8 different emergency departments that were geographically and socio-demographically diverse across the United States. Some of these were small community emergency departments, and others were really large tertiary care ED. So we had a nice variety of ED types within those 8. And what we found is at baseline, which is the phase all the way to the left, where you see the 26%, about 26% of all of the adult patients presenting in those 8 emergency departments were being screened for suicide risk at baseline. And then we pulled together continuous quality improvement teams. You guys are familiar, of course, with CQI. So we had teams at each of the 8 sites convened, and their job was to implement the universal suicide risk screening at their site. So they typically we used an Institute for Healthcare Improvement model as a pretty simple model using plan, do, study, act cycles and other tools in order to implement and monitor, and then of course improve universal suicide risk screening. And what you see in the middle column here, where you see 73%, this is the efforts after we began implementing the universal screening, and you can see that we increased from 26% to 73% of all patients during the middle phase where we introduced screening. And you can see also that there's an improvement over time in the final phase when we introduced another intervention after the emergency department visit, which was a telephone phone intervention. But we still continue to work on improving the screening in the EDs, and you can see a continued improvement. And in this final phase, we got up to 85% of all the adults who presented to these EDs were screened for suicide risk. And I think about 85, maybe 90% is probably the maximum that you could screen in an emergency department, because a lot of the patients are presenting and can't be screened. So you'll never really get to 100%. So, but we considered this close enough to consider that we had a universal screening implemented. And so what happened after we did this to the detection rate? So did it actually lead to the outcome that we thought it was going to? And yes, it does. About 2.9% in our treatment as usual phase were identified as having suicide risk during our usual care practices. And you can see that as we improved the screening, we improved the detection rate all the way to, in the final phase, it averaged around 5.7% of the patients were identified as having suicide risk. Now, it's really important to consider that we demonstrated that it was feasible to do the screening, and that when we did this improved screening, we actually improved detection. But we also recognized that it was pretty easy to document that you did a screening, because you could document that you do a screening and the person's negative and never ask them the questions. And this is a pretty common thing in medical settings where we document by negation. So if it's not there, we say, no, it's not there, even if we didn't necessarily fully screen or ask the questions. So there was a concern that we might be increasing documentation of screening, but not actually increasing the actual screenings themselves. So what we did is we had research staff go in and sample a group of patients, randomly sample patients who had a negative suicide risk screen documented on the chart. And then we went and asked those patients whether they were actually asked the questions. So in other words, we had a fidelity measure here to make sure that the questions were being asked, all the questions were being asked, and they were being asked in the right way. And what we found is probably not going to be too surprising. If you work in a busy emergency department, you'll recognize that this is just part of the nature, and unfortunately, of working in EDs and documenting in a busy setting. What we found is when we looked at suicidal ideation, only around 60 to 70% of the patients who had a negative documented screen actually had been asked the questions. So ideally, that would be 100%. Everyone would say, yeah, I was asked those questions, and the answer was no. You know, I didn't have thoughts of killing myself. So what we found in phase 2 and 3 is it started off in phase 2 at around 60%, and then it improved to about 71% in phase 3, because we were really focused on trying to improve this fidelity. And then the same thing occurred, but in even greater disparity for the suicide attempt question. So only about 50% of patients who had a negative lifetime suicide attempt documented actually were asked the questions, and that improved around 60% in phase 3. And you can see that this is not a mystery. I think what was happening is if the person was negative on the suicidal ideation question, they just didn't ask the suicide attempt question because people didn't think it was relevant if they were not currently suicidal. So that's the reason why we saw this big drop. So in conclusion, is it feasible? Yes. Is it easy? No. Does fidelity have to be attended to very carefully so that people understand that they shouldn't document a negative screening if they haven't actually screened the patient? Should you create an electronic health record response options for your screening questions to allow clinicians to document that they didn't ask the question so that they're not forced to answer no when they actually didn't ask the questions? That's definitely something that needs to be done. Does it require a team to implement this that's going to pay attention, that's going to collect data, and that's going to use the improved model as part of the zero suicide model? Do we need a CQI model? Absolutely. Otherwise, I don't think it's feasible. I think you have to make sure that whatever you do, and we'll talk a little bit more about this at the end, you have to answer the question of once you open Pandora's box, what are you going to do with it? How are you going to manage these newly identified screens that you weren't identifying before? So we'll talk a little bit more about that at the end, but I want to move more to some of the latest advances. So this stuff with the ED-Safe is relatively old. We use very static screeners. We use the patient safety screener, which is a 3-item screener designed to be very quick, yes, no items, and validated. It's a validated screener, so it's evidence-based, but it was really designed to be administered by nursing staff in a very quick and efficient way. So it's a pretty bluntish instrument. If you screen positive on the first 3 items, there's an additional 6 items that can be answered that gives you a stratification between mild, moderate, and high risk. So it does come with a sort of secondary screening process that does a better job, but it's probably not ideal. I still think it's pretty crude. So what have we been working on lately to try to improve the screening methodology? And I'm going to talk, there's a lot of different options out there, including electronic health records, machine learning algorithms, but I think what's closest to actually being deployed and is being deployed in some emergency departments across the country and has got a very mature science base is a computerized adaptive test, so what we call CATS. The reason why CATS might be preferable to our cruder screening instruments is because they're fast, but we have equal accuracy as a much longer instrument. So you might be able to administer only 5 to 10 items, but it still is as precise as if you administered 100 or 1,000 items. So that's the magic, the secret sauce for CATS is that it does it quickly. So it has the strengths of a quick screener, but it actually has a lot more precision and accuracy. Has a lot more potential for scaled measurement. Our crude instruments kind of force us into these blocks. It's either yes or no, the person has risk or they don't have risk, or at most you'll get 4 strata. You'll get negligible risk, mild, moderate, or high risk. That's pretty much what most screeners are going to deliver. Whereas CATS can actually have a much more valuable gradient of severity so that you can use it to bucket people into pathways if you need to, but you also get a spectrum analysis, which we all recognize is important. It's controversial in the field. Idea of stratification and bucketing people is not really embraced by many suicidologists. They really prefer more of a spectrum and more of a complex risk formulation approach than the bucketing that the screeners do. So CATS can potentially help with that. And that's because they can assess multiple dimensions. The screener we used for ED-Safe and what many people are using, like the Columbia, is monodimensional. It's only assessing suicidal ideation and behavior. So it's really just that we're basing our judgments on. When we do know as people who are invested in understanding suicide risk, that's not the most important. That might be important, but it is more important that you gather a lot more information about the patient and you pull all that together to really understand where the patient is. Their depression, their PTSD, their substance abuse, their trauma history. So there's a bunch of other components that are important predictors of future suicide risk that are in addition to suicidal ideation and behavior that we really want to pull together. And what a CAT can allow you to do is potentially assess multiple dimensions that are really important, both in and of themselves and in their relationship to suicide risk, in a very fast and efficient way. If you had to administer one of our other, kind of crude screeners, if you work in settings that use the PTSD screener and the PHQ-9, the G87, to administer all of those instruments in the emergency department setting is just not realistic. But it can be realistic to administer CATs, particularly because many of these CATs use they tap into the same item base, so you can actually squeeze it into a pretty quick assessment. And it does all the scoring, et cetera, automatically for you, so you don't have to worry about having staff scoring instruments, which is just fraught with error. The final thing is it can improve fidelity. Remember that part I told you about fidelity. Human beings will make mistakes. They won't ask the questions the way they're supposed to ask them. They won't ask all of the questions when they're supposed to, but computers don't have that problem. They don't miss items, and they don't vary the way the questions are asked. So the standardization and fidelity is improved. So there's a lot of reasons to think that CATs are going to be preferable to our traditional human-based screening. So I'm going to talk about just 2 studies. There's dozens and dozens, maybe hundreds of studies on CATs and their validity in assessing factors related to suicide and suicide ideation behavior. I'm going to talk about 2. One that we published with Robert Gibbons, who's preeminent in the field of CATs, and we developed one that was specific for suicidal ideation and its relationship to suicidal ideation. And we used a 1,008 item bank of mental health issues that included 11 suicide-related items. We identified the 100 items that were most highly related to suicidal ideation in this large pool of patients, the 789 patients. And then we validated the CAT against a risk, CSSRS administered by trained research staff. So that was our criterion reference, and they were blinded to the CAT results. So they did an independent evaluation of the patient. And bottom line is we found that we had really strong operating characteristics with around 10 items. We could get a correlation that was near perfect with the 111 item scale that we originally derived. And in terms of detecting any ideation, suicidal ideation that was detected by the trained research staff, we had sensitivity of 100 and specificity of 95. And then detecting a high risk alert, in other words, suicidal ideation with a plan. So how well does it do to detect the low strata, so any risk versus not, and then how well did we detect something that really is concerning, suicide ideation with a plan. And we found sensitivity and specificity of 1 and 89.89. So the operating characteristics of the CAT in these circumstances were good, but this was a validation against a criterion reference. An interview, what about suicide attempts? What about future behavior? Well, the ED STARS study, which was with adolescent patients, validated the CASI, which was a computerized adaptive test specifically designed for the emergency department for adolescents. And they had 2 studies that were complementary. One was a derivation study, and they found the area under the curve of 8.9 for predicting any suicide attempt in the following 3 months with a mean of 11 items. Now, this is really powerful if you think about actually trying to predict suicidal behavior. Suicidal behavior is notoriously difficult to predict, yet with an average of 11 items, the CASI predicted suicide attempts. Probably, they didn't compare it against pure clinical judgment, but it's probable that this is way better than typical clinical judgment. And they did a second study to validate their original findings to make sure they were robust in a separate set, a new set of prospectively enrolled patients, adolescent patients, and they found very similar results. So superb area under the curve, good sensitivity and specificity in predicting suicide attempts. So these are 2 really important and emblematic studies on CATs. I think it really is where we need to promote the field. And the reason is because I think CATs and something called clinical decision rules can go hand in hand. In the emergency department, clinical decision rules are really important. Because in the emergency department, resource allocation and efficient throughput is hugely important. So what's happened over time is we've developed methodologies to try to make better, more efficient decisions that balances out the health of the patient and making sure we're doing the patient justice and providing really good care, and the resource utilization of the emergency department and the rest of the health system, so that we can provide more efficient care. So that's really, I think, where we're going to need to be, especially as emergency departments continue to have increases in volume, and efficient care that's effective is going to be essential. And I think what we are doing in our research and others is trying to figure out how we can blend those things. How can we blend clinical decision rules that help with efficient care with tuning, with computerized adaptive tests that help us to make those decisions? So that way we aren't, for example, having observers do one-to-one observations with patients that really aren't at risk for suicide, and therefore that observer is a wasted resource. That observer could be doing something else. In many emergency departments, for example, the people who are the observers are actually people who should be doing other things. They're patient care associates or techs who could be doing other things, and they're taken away from those jobs in order to be able to do the observation. And when they aren't, then you have to hire sitters, and that's their only job, is to sit. So you're basically paying someone to do an observation. And if you're paying people to do observations on patients that don't really need observation, you're wasting money, and it's intrusive, it's not fun, people don't like it. So there's all kinds of reasons for us to really want to make more effective and efficient decisions. And I think CATS combined with clinical decision rules is the wave of the future. So all that said, whether you're using a traditional screener or whether you're using something fancy like a computer adaptive test, what are you going to do if you're going to apply this universally? If you're going to open Pandora's box? I mentioned earlier that there's some provisos for the feasibility of universal screening. You really have to have right-sized care pathways. So this goes in, dovetails in with what I was saying earlier about the resource utilization. You have to establish a very clear protocol. People can't be confused or vague about what they do when they ask the screener, and if they get a yes, or if they get a mild, moderate, or high risk. There can be no ambiguity. Your institution has to have very clear policies and procedures around the stratification of those patients and what happens. So you can't treat all risks the same. We were originally, most of the emergency departments that we worked with were treating all risks the same. It didn't matter whether the person was presenting with mild risk or imminent risk, whether they had tried to kill themselves with a near lethal attempt, or if they were having passive ideation and were just expressing frustration because they felt like they were trapped and felt like they just would die and not wake up. So we were treating all these people the same, and it was a huge resource burden. And the idea that if we added new people who were medical patients who also had suicide risk to this, that it would break was true. It would have broken. So we didn't do that in ED-Safe or SOS. Instead, what we said is, how are we going to treat the mild risk patient differently than the moderate risk and differently than the high risk? And as an example, here all the way to the right, we have our clinical pathway that is used in our acute care settings. You can't see the details, but this little peach box here is for the mild risk patients, and those patients don't even require a behavioral health evaluation in our health system. They're offered one, and it's up to the judgment of the clinicians as to how important they think it's going to be. But it's not a requirement of our protocol that they receive a behavioral health evaluation. But what they do need is to be provided with a behavioral health referral resource upon discharge, and suicide prevention psychoeducational materials that are printed with their discharge paperwork. So we consider behavioral health evaluation, but it's not required, and we simply require that the person receives a referral to outpatient care if they're discharged, and psychoeducation. So we felt like that was sufficient for a mild risk patient, and we didn't have to do observation, and we didn't have to force a behavioral health evaluation. And then the moderate and high risk are stepped up from that with additional safety protocols and requirements for behavioral health evaluation. But this is how we were able to actually address all of those extra patients that we were identifying when we weren't doing the universal screening. I also would suggest that if you're going to open Pandora's box and you're going to push out universal screening, that you pay attention to fidelity. That means that number one, when you're training people to do this, they all know and understand that it is not acceptable to document a negative screening if the person was not actually screened. If the questions were not asked, if the patient or the collateral, then they should not document a negative screening. And then that needs to really be reviewed regularly with staff. Every new person who's hired, that would need to be reviewed with, and the standard training on the screening should be provided, because that was something else we noticed, is that as new people came on board and they were trained, the training was a lot lighter than what happened when we did our initial rollout. And many of those people were missing this important information that they should not be documenting a negative if they didn't actually ask the questions. Instead, they should be documenting either the patient refused or was unable to, or they were unable to do the screening, which were options for staff to choose. So you really need to focus on fidelity if you're going to do it, and if it's going to mean anything, and it's not just going to end up being an exercise in documentation on the chart. I'm going to close with this recommendation. So what happens when we all, especially in emergency medicine, start to focus on care pathways? That's a fundamental part of the zero suicide model. So they're indispensable. Care pathways, protocols, policies. I think that they have to be in place, or else too much ambiguity and confusion exists, and we don't have efficient and effective care. But also what happens is you start to focus on the care pathway. You start to focus on the way the system works, and designing something that's going to be efficient for the system and for the clinicians who work within the system. The more we do that, often the more we get away from what's most important to the patient. So there've been really nice studies, qualitative studies that actually talk with patients who are suicidal about what they want, and psychiatric patients in general. And often what they want from the care in an emergency department or acute care unit is very different than what we think they want. When we think safety, we think, okay, we're going to make sure that they don't have access to lethal means because we don't want them to hurt themselves on the unit. That's the most important thing. It's a zero event. It's going to be a sentinel event that we have to report if this happens. So we really focus around keeping patients safe. But patients actually don't necessarily think of it that way. What they want is respect. Their idea of safety is treating them with compassion, treating them in a way that's informed by our understanding that many of these patients are traumatized. So trauma-informed care. They want to feel like they can trust the clinicians who are working with them to do the best for them, and not to overreact if they share that they're suicidal and get the security guard involved and have to strip search them and admit them to an inpatient unit. That's not safe for care for many of the patients who are suicidal. They want something better than that. They want something different than that. And they're afraid that if they share that they're having thoughts of killing themselves, that what's going to happen is all of these other scary procedures are going to be put into place, and it's going to make them feel vulnerable. It's going to make them feel traumatized, not safe. So I think we have to be really conscientious about providing compassionate care, as well as our best practices in evidence-based care. I found this interesting diagram all the way to the right that reflects what evidence-based practice really means. We often think of it only as the blue box, the best research evidence. We think that's what evidence-based practice is. But I really think that it involves these two other domains: clinical expertise, so best research done without a clinician, carefully considering the individual circumstances of a patient is really just protocolized care, and it's not going to be better than what we've had before. We do have to incorporate clinical experience, and as importantly, we have to pull in the patient's values and preferences in our decision making. So evidence-based practice really is much more than just knowing what the best evidence is out there and trying to apply it with your patients. It really requires these other components too. So this is a cautionary tale, because no matter how much I keep this in mind and have tried to have it guide my efforts in all of the places I've worked, it is a real challenge. And I can say that I haven't been always successful. And it's a part that we are continuously having to work on, making sure we're keeping the patient preference, their values, and understanding of the patient's perspective infused in our trainings and in our protocols, so that we can really give people what they really need, while at the same time considering what the system needs. All right, I'm going to conclude there because I wanted to leave some time for questions and answers, and I'll leave this up just for a little while because I try to include all my collaborators and acknowledge their assistance and all the work that I do. So I'll leave this up and I will open it up to questions.
Sounds good. Thank you, Dr. Boudreaux. And we do have a couple questions here. Our first one, and I would also suggest anyone please put your questions in the Q&A box. Question number one, how would you suggest ensuring fidelity? Would you advocate for inclusion of this question on EDCA-HPS surveys sent to patients?
That's a really good question. So I think the first component of fidelity is always training. And so if we look at the kinds of training that we usually push out, because training is a huge challenge. Anyone who's worked in any health system knows that training existing clinicians is challenging because they often don't have the protected time to be able to complete the training. So what happens is we get pushed these virtual trainings on your virtual training platform within your health system that are superficial and that people just do kind of, the lip service to. That if you're like me, I'm my compliance training, I'm scrolling through. I already know how to wash my hands, so I'm just scrolling through, I'm taking the quizzes and I'm trying to get through it as quickly as possible. If that's the way you're training your nurses or whomever you're expecting to do the screenings, then you're inevitably going to have poor fidelity because people are not really getting it with those trainings. So I would say you really should consider how you're training your nurses from the beginning and how you're going to do regular in-services to make sure that the training sticks. I think that at minimum, some type of in-person training, even if it's your training for 15 minutes during the initial shift, during a huddle or during a lunch and learn, that you really do have to walk through each component of whatever training you're doing and make sure that the consistent message is you have to ask the questions and you have to document the answers. If you can't ask the questions, then don't document the answers yes or no. Document them as not being administered. So I think that fidelity begins at the very beginning, and it has to be viewed as an ongoing process. Some of the innovative ways that we've found that places have used are having the nurse managers doing a debriefing spot checks with their nurses. They often have to do this anyway as part of their other job, as part of their jobs of making sure that nurses are doing what they're supposed to do for all patients. So they are, many places already have this role, either as a resource nurse or a nurse manager or a nurse educator, kind of checking in the real world with nurses and saying, okay, let's talk about that case. And they do kind of a debriefing after the case. It's not like they're there watching. Sometimes they actually will go into the room and watch and listen to what's going on. That's the optimal. So if you can do that, then you do that. It's not always realistic. You can do a debriefing and talk with them and ask them, look, and it has to be done in the right way. It has to be done in a way that's no blame. That's let's work on this together. And you can ask, and I've found, and I've had feedback from our nurse managers that when they ask the nurse, this patient screened negative on the suicidal ideation question, did you ask the question? Many of them they're honest. They said, no, I didn't ask the question. I just didn't think he was suicidal. And then that's an opportunity for feedback that they're, in real time. I think at the end, if you wanted, so to answer the specific question, if you wanted to add these questions to the post-visit survey, I think you could possibly do that. I've never done it that way, and I'm not quite sure, what you would get, because the post-visit survey is often done quite a ways after the visit, and you would worry that there would be some decay in recollection. In our studies, we've asked the patients while they're still in the ED, while the information is fresh, as close to the documented screening as possible. So we were pretty confident that there wasn't a decay in their memory. That was my only worry about adding it to a survey after the visit is, you might not be getting accurate recollection.
Excellent. And then another question came through. What tools or approaches have you found useful in measuring compassionate care and integrating patient values?
That's a really great question. I haven't found many options out there for trying to integrate training for compassionate care into our protocols. This is one area that I'm just going to be honest that we've struggled with. I'll tell you about a success that we had. It was a limited success, but what we were able to do is get one of our nurses who had a real passion for this issue to create her own training on compassionate care that was brief enough to be realistic to deliver. It was 60 minutes. And was very focused on being very, very practical and some very practical communication tools. And it was very well received by the nurses and the physicians that she delivered this training to. And it was done well, and it was done by the nurse. So what I've noticed is if I'm coming in and trying to help organization with this, that it's not really well received. If you can find people, champions within your own organization, who can come up with and use, you use the literature to inform this, but they can come up with their own training on tips for compassionate care. That might be one way to make it realistic and better accepted. When it's being delivered by one of your peers, then you're more likely to accept the message. In terms of measurement, there are a few measures out there that have been used that are basically satisfaction measures that you can deliver to patients. So most patient satisfaction measures will have something around compassionate care. Usually it's around whether they thought they were being treated with respect and with the communication. So Press-Ganey has satisfaction measures, and there are some compassionate care specific measures. I think one of them is called CARES that we've used in ours, and we measured the patient's perspective rather than the clinician's perspective on whether they're delivering compassionate care. That's probably the best way to figure it out, because it's really whether the patient feels like they received compassionate care that you're most worried about. So one measure is called the CARES, and then any other satisfaction measure, which is nice because the satisfaction measures are probably already being administered as part of your routine care. And if you can segment the suicidal or psychiatric patient population from what you're getting from Press-Ganey or from one of the other satisfaction measures, it may be already something that you can use that's not extra, because anything you add extra, of course, it has extra costs and complexity. So if you can use an existing measure, but the only way to make it really, I think, useful is if you can segment out patients who might have been psychiatric patients or suicidal to really drill down to that.
Excellent. And another question, are there any studies showing whether patients are more likely to answer questions honestly on CATs versus an in-person interview?
Yeah, that's a great question. So there's a huge literature looking at self-report measures, not just CATs, but self-report measures, paper and pencil or other computerized surveys that are not computerized adaptive tests, because you can just take any instrument and computerize it, like the PHQ. So the literature that typically that's been, and there's a recent meta-analysis on this, typically finds that if they're either equal, the interview and the self-report measure is either equal, or the self-report measure is going to do better or identify better, quote unquote better. It's going to identify more pathology than the interview, the person-to-person interview, especially if it's stigmatizing or sensitive topics. And that makes sense. We know about social desirability bias. This has been part of what we've recognized is true in our interviews with patients for a long time. And so you can imagine that if you remove some of that social desirability bias by putting it on a computer, then you're more likely to get people to disclose things that would be difficult to disclose by interview. So either it's shown that computerized or self-report is roughly the same, or you get more accurate, more honest feedback from the computer, especially with sensitive information, stuff like mental health, substance abuse, and domestic violence. So yeah, the CATs are going to be better for that reason, but also because they don't have a problem with fidelity. They're going to ask the questions the right way every time.
So we have a couple of attendees who are curious on how to get more information on cats and specifically where we can get the cat's form. Are you able to point them in the right direction?
Yeah, so I work with a company called Adaptive Testing Technologies. I don't have a financial relationship with them. I work with them scientifically. Adaptive Testing Technology is one of the premier cat companies. So you can look them up on the web and find information from them. They're the ones I'm most familiar with. They actually have the cat that I described. They have both of the cats that I just described, the Cassie and the one for adults, the cats for suicide. And also there are computerized adaptive tests that are options in some of your electronic health records. So the NIH invested millions of dollars to create something called the PROMIS measures. PROMIS measures measure a whole range of mental health and behavioral health outcomes, including not just depression and anxiety, but things like pain and sleep and dozens of measures. And they've created computerized adaptive tests that have been integrated in some electronic health records. So if you want to know about those, you would search PROMIS, PROMIS, patient reported outcomes. I forget the rest of what PROMIS stands for, but and you can find options for accessing the PROMIS measures. They have them integrated already into some EHRs, and then they have an outside organization that also sponsors them. So those are the two that I think are most dominant in the field right now.
Excellent. Another question we have, suicide is now the second leading cause of death in our teen population. Do you think all secondary schools should conduct suicide/mental health screenings? And if so, how can you envision how this happens?
Yeah, it is. It's a huge problem, especially with COVID and with just the escalation in behavioral health related issues that we've seen in teens and young adults. I mean, the same thing is true for the young adult population in colleges and universities. They're overwhelmed with the burden. So I think that universal screening within those settings is feasible, and there are places that are already doing universal screening in educational settings. So I don't know the literature on this, though, so I would be remiss if I didn't kind of put that as a proviso. I don't know exactly if there are any really good studies that have evaluated the feasibility and have worked through some of these issues that I just described. Because what I'm afraid is going to happen is what I see happen often already. And that is, if a person screens positive, they're going to send the person to the emergency department automatically. And I think it's a horrible practice. And I see it all the time in our EDs with children being sent from schools because the schools are so risk averse, particularly with all the stuff happening in schools, that they have basically a branch. If you're negative, then they don't send you to the ED. If you're positive, they send you to the ED. There's no variability. There's no right-sized care pathway. I would say if you don't have a right-sized care pathway to address any the range of risk you're likely to assess, then I wouldn't advocate for screening. I think more harm would be done than good. If you send all patients, all teenagers who have thought about killing themselves or who have thought that they're hopeless and wish they were better off dead to the emergency department, you'll end up training them right away that they shouldn't tell you that they should hide it, that they should avoid admitting to that because it's going to be a terrible experience for them. I'm just sad to say. So I think that universal screening should only be implemented. A careful thought has been given to how those different levels of risk are going to be addressed, with only those who are judged to be at the most imminent risk being sent to an emergency department.
Okay, and another question, would the CAT replace the clinician live interview? Are there liability issues related to using a CAT versus having a live interview with a clinician?
Yeah, that's a good question, and this is definitely important to ask, and it surrounds this issue around use of CATs and how how the interface between the computer and the tech and the human being has to happen. So first off, I would never advocate using technology as the sole way of identifying and managing a patient. We're not there. I don't think we'll ever get there yet. There's a concept called the human in the loop. When you look into digital health and you look into machine learning types of research, where there's a real recognition that you still need a human in the loop. And so I look at the CAT in the same way that I look at any other diagnostic instrument. So the diagnostic instrument, let's say you're going to do a X-ray, a CAT scan, an MRI. It's a tool that helps you to understand the clinical picture better, but it doesn't drive all decision making. There are going to be some cases where the diagnostic test is very clear what you should do. If you do an angiogram and you see a blockage in a coronary artery that's greater than acceptable, you know the next step is going to be to put in a stent. If you see a fractured bone on an X-ray and it's very clearly fractured, then you know the next step is going to be to either do surgical reduction or to put the person in a cast. So there's times where those diagnostic instruments are going to tell you exactly what you should do, and they're going to relieve a lot of the question. But there are times where that's not true, where those diagnostic images or results are going to be somewhere in the middle, and it really requires a human being to make that judgment. Even when it's clear, the human being still has to be able to communicate those results, to understand the results, and to explore the options with the patient. And that's the way I think the CAT should be done. So the CAT could be, you could imagine a CAT being used in two different ways. You can imagine it being used as a universal screening, which is what I just described, but you could also imagine it being used as part of your care pathway after an initial simple verbal screening. So if you think about it as an additional test that helps to validate what the human being has obtained and to assess it better. So our blunt screening instruments may give a signal that says, okay, the next step is to do a CAT. And then the CAT then does a more precise assessment and helps to provide additional information that the human being is just not going to have time to get. That then allows us to be able to tailor the treatment better than what the blunt screening instrument could do. So I think those are two ways to think about it. I actually feel like the near-term deployment that we're working on here at UMass is not as a universal screener, actually. It's as this additional assessment step that happens after we identify that the person has some risk we should worry about.
Excellent. And we have time for just a few more questions. Can you speak to the care pathways and any recommendations for developing this in an ED or hospital system? More specifically, how and where to refer identified at-risk patients for follow-up care?
Yeah, so we have a lot of experience with developing these pathways. The pathway, you're going to have a choice. You're going to have to figure out what instrument you're going to use to do your evidence-based screening. And that instrument is going to deliver guidance on how you should stratify the patients. So the patient safety screener is what we use. The Columbia Suicide Severity Rating Scale triage version is very common. The ask suicide questions is really also very, very popular. And each one of them is going to have a scoring algorithm and is going to come up with a stratification, and the literature will have some recommendations for what those pathways should look like. So there's some recommendations on the Columbia website for what happens if the person is in the high risk range, for example. So I think you have to start there. Your pathway is going to be guided by the instrument you're using to be able to identify them. And then you have to layer in what is realistic for your health system. So that has to be really, I think, an important consideration. You have to balance, once again, the efficiency of care with the resources that you have. Some places are going to have, especially tertiary care hospitals, are going to have mental health providers on site. So you may have a psych ER, you may have a behavioral health nurse or a behavioral health provider that's there to be able to do additional evaluations. I found, for example, that pediatric emergency departments often have more resources than the adult emergency departments to do this kind of work. They may have a social worker, for example, who could come to see all the positives and do a secondary brief assessment to determine exactly what should happen with that patient and to provide behavioral health referral information. So if you don't have that kind of person, though, and you're in a hospital that has no behavioral health, and the only option is to send the person to another place. We have a hospital like that in our system. The only option is to send them to the tertiary care hospital. There's no behavioral health on site at all. So there's basically a binary decision making there. Are they sufficiently imminent that we need to transfer them, or are they not? And if they're not, then what are we going to do? Can we get a social worker to come in just to have an evaluation of their behavioral health access? So a social worker might be a good person you could bring in for those patients that you don't think need to be transferred or who are not at the highest risk, to have a discussion around behavioral health and primary care access, because that's ultimately what you're going to be doing, is recommending and giving them a referral. Now, when I say a referral, there's a bunch of different ways to do that. The gold standard is going to be to identify some organization that can actually schedule an appointment with the patient before they leave the emergency department. That's the gold standard. That's the ideal. That's the ideal. And we all recognize that that would be the ideal. But that's difficult to do. It's really challenging. So what happens in practice is usually the social worker or someone, or maybe it's just a list, has a list of options for the person in the community, and they give that to the patient. So the worst kind of referral is unfortunately the most common, and that's just a list of providers. But at minimum, you need to do that. And I would say two things about that. Number one, you need to make sure it's updated. When I first came to UMass, I took the referral sheet that they gave us, and I started, first off, you could barely read it. It was so overcopied that it was blurry. I called the top 10 numbers, 5 of them were out of commission. And this is what they were given to every single behavioral health patient. So 5 of the top 10 numbers on that list were wrong. So if you're going to give them a list, at least make sure it's accurate. The second thing I would say is it's useful to cluster the list based off of people's insurance. So the list that we had at UMass was just a list of providers in the community, had no organization whatsoever. And most of the patients we were giving it to had Medicaid, and almost none of the organizations on the list accepted Medicaid. So what were we doing? We're doing worse than not giving them anything. We're giving them a false hope. They call in numbers, they're wrong, and then they call and finally get a hold of someone and they don't take their insurance. Of course, we have a behavioral health access problem if we're doing that. So I'd say make sure they're accurate, make sure that they're clustered based off of what kind of insurances. And it can be big group clusters, because typically there's going to be providers that accept Medicaid or some sort of state health insurance, and be providers that accept private insurance. So cluster it, help the patient out if that's the best that you can do, and not actually scheduling appointments for the patients.
Right. Do you have any special considerations for our geriatric population? Would you make an exclusion for dementia?
Yeah, I think that so many of those people, so if you looked at our percentage rate, we got up to 90% in a follow-up study, 85% in the one I just showed to you, screening. Those 10 or 15% that we're not able to screen are often the elderly, impaired, delirious, and dementia patients. So what we implemented here is we have a response that's on our screener that says patient unlikely to be screenable during the visit. So in other words, if they have severe dementia, you're just not going to be able to screen that patient during the visit. So that kind of takes it off the board. But if it's due to something that's transient, like we think it might be intoxication, or the person might be delirious and they're having some variability in their altered mental status, then they just postpone the screening, and it pops up again 24 hours later if the person's still there, to prompt the nurse to do a rescreening. So we've programmed it there to try to help us with a lot of these patients who are just not in a mental state when they first arrive, but who could be screened later once they clear up. And I think that's an important consideration, not just for the elderly, which it happens most frequently with, but also other patients who are presenting with some sort of transient altered mental state.
All right. Why use the blunt instrument screen first if the CAT has better fidelity and psychometric properties?
Only because of practical considerations. I suspect your emergency department doesn't have a tablet PC or a kiosk in every room. So how are you going to get the person to complete the CAT? In our ED, we actually do, because of the work that I do, we have a tablet PC in every single room. So it is designed to actually collect information from patients, including surveys. So we could do it in our emergency department, but even though we have a tablet in every single room, it's still challenging for us to get the nurses to administer the existing screener we have on those tablets. It seems like a simple thing, but we've had challenges with it. And so imagine that we're going to do it universally through the tablet by having the nurse introduce the tablet to the patient and have them complete it. Already didn't work with our non-CAT electronic screeners. So we figured it probably wouldn't work for the CAT either, at least not yet. So it's merely practicality. If you have an emergency department or any kind of clinic you think can reliably administer a CAT on a computer, that's definitely the way to go. It's going to be far, far superior to using the blunt instrument first.
Excellent. We've got two more questions for you, Dr. Boudreaux, if that's okay with you.
Sure.
You mentioned the importance of referrals after discharge. Some of the barriers I have encountered are insurance limitations and long wait lists for those that accept specific insurances. Also, during the pandemic, in-person services have been reduced and for specific populations such as the elderly. This has been a difficult thing considering technology difficulties. Any comments or suggestions?
Yeah, we're in a real sad state in America. Our behavioral health system is broken everywhere, even in states like Massachusetts, where it's considered good. It's still not great. So I wish I had some words of wisdom. I wish I could create behavioral health capacity. I can't. But what we have done is SAMHSA and the Suicide Prevention Resource Center has created best practices around care transitions and made recommendations for how you might be able to identify and work with specific organizations through using memorandum of agreement that they can help to provide outreach to patients and provide a sort of a bridging service to be able to provide counseling and crisis management for the patients before they, while they're transitioning to outpatient care, or you can make arrangements with specific outpatient providers to be able to accept urgent care clinics. So we've done that here to some effect. We've partnered with our community mental health center system to be able to provide urgent care slots. These are just walk-in slots. And when we have a patient who has Mass Health, our state insurance, our Medicaid, instead of scheduling them an appointment, we say, look, Community Health Link, the organization, has urgent care visits from 9 to 1 every single day. So tomorrow, what you should do is show up to this urgent care and they will see you and they will try to find and identify a provider for you. So we have this agreement with them that, and if patients show up, they don't even need an appointment. They just have to show up and then CHL takes it from there. So we only have that for our Medicaid population. For insured and Medicare populations, we don't have that kind of service. But I think you have to think creatively. How are you going to work with your community-based organizations? How are you going to develop agreements? How are you going to maximize the availability of urgent care slots? Because a lot of community mental health systems have these urgent care slots. And a lot of times those urgent care slots are not even being filled. So can you do a better job with connecting your ED to the existing services in your community by doing agreements and by looking for urgent care slots?
And our final question this morning, can you talk a little bit more about the difference in the protocols between how they care for moderate versus high risk?
Sure. The biggest difference is the safety precautions that we use. The high risk protocol is 1-to-1 constant observation. I think you all know what that means. The person is searched, their belongings are searched. They are not allowed initially at any rate to have access to their phone. There's a visitor policy that requires that if the person has a guardian, then there could be one guardian present, but other than that, they limit the number of visitors. They have a safety food tray, so finger food, no utensils, and a few other of those safety precautions that are very common. Basically, these are the most secure and most we have the most precautions for those who are at high risk. For moderate risk, we use 1 to several observation. It's still constant observation, but one observer can observe up to 4 people. So we can cohort them, unfortunately, in the hallways. I'm not saying this is great care. I'm just telling you what we do. So I don't think we should do this, but we don't have an option. We cohort them in the hallway. We have one observer who's watching 4 people at once. And those individuals can have up to one visitor, and they actually have some of the same protocols. They have their belongings are searched. Any visitor who comes has to have their belongings searched. It's similar for the high risk, but they're more likely to have the visitor, and they're more likely to be able to get their phone back, depending upon if the physician thinks that it's appropriate. The problem, of course, is when you have 4 people sitting side by side, you can't have one of them have their phone and the other one's not. So you do have to, it's a consideration at the time that the clinician has to make. But the biggest difference is the one-to-many observation in the restrictions.
Thank you so much for everything today, Dr. Boudreaux. That was a great presentation. And everyone, I appreciate all the questions. Thank you so much. I would also recommend you hop over onto Dr. Mike Hogan's presentation that just went live a couple minutes ago. So Dr. Boudreaux, thank you so much. Really appreciate it.
You're welcome. Thanks. It's a pleasure.
Take care, everyone.